Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Nuno Neves from Porto, Portugal. Dr. Neves is the chair of the Orthopedic Department and head of the Orthopedic Spine Unit at Hospital of Porto, Portugal. He completed his residency in orthopedics in 2006 at the Central Hospital de São João, a spine surgery fellowship in Paris, France, and a visiting spine fellowship in Philadelphia, United States in 2008. Dr. Neves is a professor at the Faculty of Medicine at the University of Porto and earned his PhD degree in 2017. Dr. Neves has been the president of the Portuguese Spine Society. He's Secretary General and Chairman of the Spine Section of the Portuguese Society of Orthopedics and Trauma, Chairman of the AO Spine Portuguese Council, and the Portuguese National Delegate to the effort. Dr. Neves has several publications to his credit, and today it's my great honor to introduce you to Dr. Nuno Neves from Porto, Portugal. Over to you, Dr. Nuno.
Well, thank you, Tesh. It's a great honor and a pleasure to be with you today. So this is great to have this online possibility to talk to everyone everywhere in the world, especially to a place that I've visited a long time ago. For this talk today, we'll be dealing with degenerative cervical spine. And I think this talk is very interesting for those of you who are residents, those that are starting their surgical independent programs, but also for those who are doing general orthopedics or other specialties, because many times you see patients that have problems with the cervical spine, and then you don't know exactly what to do and how to do it, and maybe this will help you lead the way there. So in terms of the agenda for today, so we'll deal first of all with the common clinical pictures of the cervical degenerative spine. Then we'll look a little bit at the pathogenesis and especially the clinical evaluation, which I think is the most important. Then we'll do something with the imaging exams. And then at the very end, we'll deal with the management principles. I won't go to too much detail, but looking at general principles of management. Okay, so when we think of degenerative cervical spine, many times you look at this as kind of the called spondylosis, the arthritis of the spine. So you see many ways of talking about this: spondylosis, spondylodiscarthrosis, arthrosis, and all that. But this all means just that the spine is getting older and it's getting degenerated. And as it gets old, sometimes it gets problematic. You have certain situations when people with their aging spine develop symptoms. And when you look at the cervical spine, you can categorize the symptoms mostly around these three main possibilities. So neck pain, then you have the cervical radiculopathy, and finally, the degenerative cervical myelopathy. Sometimes they are very discrete, so you can perfectly identify one of them, but many times you see a combination of these clinical pictures. And so for the next few minutes, we'll deal with each of them and the specificities of each of them, and then we'll move on to the diagnosis. So neck pain. Neck pain is very, very common. I'm very sure that most of you will have experienced some kind of neck pain, especially for us surgeons. We do have lots of neck pain. The incidence of neck pain is very high in surgeons. That is probably related to the position we use to operate patients. It's interesting, it's more frequent in women and more frequent in higher educational levels, unlike low back pain, which is the opposite. It's also linked with smoking, and most of the times you see some kind of prior trauma, whether it's just a sprain or actually a real important trauma. Now, besides low back pain, which is probably the most common complaint in the general practitioners, neck pain probably will come number 2 or number 3. So it's really, really common. So why do we have neck pain? Degenerative neck pain, I mean. Degeneration in the cervical spine happens as exactly as it does in the lumbar spine. Now, the difference is that the weight that our discs and vertebral bodies sustain in the cervical spine is, of course, different from what we have in the lower lumbar spine. Nevertheless, degenerative changes affect the discs and eventually the facet joints, and so you have pain that comes from this degeneration. You have nociceptive endings at the periphery of both of the discs and the articular capsules, which will mediate from the periphery the nociceptive signals to the central nervous system. But besides this, everything around the cervical spine can lead to pain. So muscles and ligaments can also be the source of pain. So improper posture, poor ergonomics, and muscle fatigue, which is pretty much seen nowadays with us being all the time in front of a computer or in front of your smartphone, which leads to poor ergonomics and eventually fatigue of your muscles unless you do train them. It has been shown that in people who have pain, there are low levels of high energy phosphates, and there's a lower muscle blood flow and higher tension in these muscles. So that is probably the most common source of pain, although you have to exclude everything else before you really diagnose muscle or ligament pain. In terms of clinical evaluation, what do these patients complain? Of course, you have pain in your neck, but then most of these patients will tell you that they have a kind of irradiation to the shoulders, to the periscapular region or the occipital region, but it's not a dermatomal irradiation. So you don't see perfectly clear dermatomal path of the pain. Now, what you can see most of the times is like your trapezius or your splenius muscles being drawn as the source of pain. So that is a very interesting way to diagnose muscle pain in the neck. But don't mistake this to irradiation, which we'll see later on with radiculopathy. There are some ways to eventually understand where does the pain come from. I mean, where is the pain generation? Although this may be helpful, many times there are confounders here, so it's very hard to really pinpoint where the pain is coming from. So most of the times, localized pain and tenderness will probably be related to muscle sprain. You do have most of the time some kind of trauma prior to this. Sometimes you have deep trigger points or pain that's worse inflection. That will be probably myofascial pain. But especially when you have pain on rotation and extension, that will be probably discogenic pain. And finally, pain that's very high, suboccipital, radiating to your ear or your occiput, probably is coming from the upper cervical spine. And so you have to check that out. Now, the differential diagnosis here is very important because we're talking about degenerative changes that lead to neck pain. And sometimes you have different pains. So you can have an inflammatory process. So always ask for your patients whether they have morning stiffness, they have the rigidity, they have polyarticular involvement or other manifestations of inflammatory processes. Also rule out infection or cancer, fever, weight loss, non-mechanical neck pain, I mean inflammatory rhythm of the pain. And finally, referred pain. Heart, lungs, abdominal viscera can all be felt in your neck or in your shoulders, and with that, making the diagnosis of neck pain hard and mistaking it for another cause. So neck pain is this. The second clinical picture I would like to talk about is cervical radiculopathy. So here, what you have is pain, sensory findings, or neurological motor deficit in a dermatomal distribution in the upper extremity with or without neck pain. It's pretty much common, 3.5 per 1,000 population, and it's mostly due to either disc herniations, especially in younger patients, or foraminal stenosis due to arthrosis in older patients. So you can see there that the nerve root is compressed either by a hard calcification and osteophytes of both the oncovertebral joints and the facet joints, or from a fragment of the disc, a soft fragment that comes out from the disc and impinges on the nerve. And that makes the diagnosis different and also makes the treatment probably different. What's interesting to see is that the simple compression of the nerve root does not result necessarily in radicular pain. So you always have an inflamed or irritated nerve root before in order to get radicular pain. Because you have neurogenic chemical mediators released from sensory neurons and non-neurogenic mediators released from the disc tissue that will play a role in this inflammatory response. And that can explain, for instance, why patients have a period of very intense pain radiated to the arm, and eventually it will go away, but still the herniated disc will be there, which means that the nerve root will still be compressed, but the inflammation has decreased, and with that, the pain has gone away. So that's interesting also for your treatment options, which we'll deal later on. In terms of clinical evaluation, almost every patient will have arm pain. There are a few rare cases where you'll have patients will only have motor or sensory deficit. Neck pain is very common, as is scapular pain, especially when you have C5, C6, or C6, C7 discs affected. Headaches are also common. Then you have the Sperling sign, which means that you rotate and compress your head to the ipsilateral side, and you'll have pain that radiates down the arm as the usual pain that the patient has. You also can see the shoulder abduction sign, which is pain that alleviates when you abduct and externally rotate your arm, like when you're lying down with your hand behind your head. And then you have this sensation of paresthesia, that is numbness and tingling, that also follows the dermatome that's affected. In terms of neurological examination, this is very important. And it strikes me that sometimes I do see patients that have consulted other doctors who have not performed a thorough clinical neurological examination. It is very important because once you do this, you almost always have the diagnosis done, and it will help you also to understand exactly what happens in the spine that, for instance, has multiple levels affected. You can see exactly which is the one that's affected. And it also helps you to understand the evolution throughout the time. So motor deficits happen in around 2/3 of your patients. Sensory deficits with diminished touch sensation will happen in around 85% of your patients, and the reflexes can be diminished or absent in around 71% of your patients. So you look at this sequentially for the C5, C6, C7, C8, and T1 nerve roots. So sensation, it's very easy for the upper limb, C5 on the lateral arm, C6 on your thumb, C7 on your middle finger, C8 on the lateral side of your hand, and T1 on the medial part of your arm. As for your motor, I use the deltoid, the abduction for C5, the wrist extensions for C6, the elbow extensions for C7, finger flexors for C8, and the abductors, the finger abductors for T1. And finally, reflexes, you have the biceps reflex for C5, the brachioradialis reflex for C6, and the triceps reflex for C7. No reflex for C8 or T1. And with this, and with your history taken, you can now make almost your diagnosis. Now, it's important to differentiate radiculopathy from other problems, especially peripheral entrapment syndromes. I mean, every peripheral nerve entrapment, can be confounded with cervical radiculopathy. Also very important, rotator cuff and shoulder abnormalities. They can be mistaken for C5 or C6 symptoms. It's very important to differentiate both of them, and sometimes it's hard. So a clinical exam is very, very important, and you really should perform both the shoulder and the cervical exam to really rule out in terms of clinical evaluation, because many times these patients will have some kind of tendonitis on their rotator cuff, and at the same time some kind of degeneration at the cervical spine. So sometimes it's hard to differentiate both of them. Then you have other brachial plexities, the herpes, the thoracic outlet syndrome, and even cardiac ischemia, for instance, on the left side, which can have that radiating pain down the arm. So differential diagnosis is very important. The third clinical picture I bring you is the degenerative cervical myelopathy. So with this, we mean the involvement of the spinal cord by the spondylotic changes. And in these patients, what you'll find is upper and lower extremity long tract clinical findings, and we'll deal with that later on. Usually, unlike the cervical spine radiculopathy, where you have patients that are around 30 or 40 years old, these are usually older age people that have had long progressing degenerative changes and that progressively have compressed the cervical cord, the spinal cord, and finally end up having symptoms from the spondylotic changes. Now, why do we have symptoms from this? It is very interesting because we do not know that much about cervical myelopathy. And if you follow spine, you see that, for instance, AO Spine is doing a big push now to better understand both the diagnosis, the pathogenesis, and also the treatment options for cervical myelopathy. And this term of degenerative cervical myelopathy is now the proposed and accepted term for this entity. Now, the probable causes for the pathogenesis of cervical myelopathy are both static and dynamic compressions of the spinal cord. So once you have more than 40% of canal compromise or less than 30 millimeters of anterior posterior diameter, or also less than 60 square millimeters of cross-sectional diameter of the spinal canal, you'll probably have symptoms of spinal cord compressions. But sometimes you do have patients that have all these static compressions and they have no symptoms at all. I mean, the spinal cord has adapted itself to this compression. So spinal canal compromise, canal encroaching does not necessarily mean cervical myelopathy. So cervical myelopathy is a clinical entity that results from compression of the spinal cord. So it's not exactly the same thing. The second possibility, you can have dynamic compression. I mean, once you have the compromised canal, you can have, when the spine moves, aggravation of the compromise. And with that, repeatedly can come up with symptoms because of that. And finally, we understand that because of this compression, the arteria that come from on the front, especially on the front of the spinal cord, the anterior spinal artery, can be compromised, and with that you can have ischemia of the spinal cord, and because of that you'll have symptoms of this. Now, what do these patients complain of? So they have axial pain, just as any neck pain, and they may have radiculopathy, just as any discal herniation. So sometimes the diagnosis can be challenging even for the other entities that I've shown you. Also, these patients will have some kind of hand clumsiness. They have difficulties buttoning their shirts, putting a thread on a needle and all that. They have a loss of fine motor skills. And many times you say, well, he's older patient, he doesn't see well, he has arthritis of his hands, so that's this problem. And you have difficulties in coming up to the diagnosis. And many times we see these patients in a very late stage of their evolution. And we should see these patients at the very beginning of the problem, because you'll see that that can make a difference in terms of prognosis. Patients can have difficulties walking. So you have the typical myelopathic gait. It's kind of an ataxic gait with a very large, wide stance and short balance. It's rare to have incontinence or retention. Usually the patients can complain of urgency, hesitation, or frequency. It's rare to have other stuff. Also, on your examination of the patients, you'll see motor weakness and wasting in upper or lower extremities. It's very common to see the interossi, wasting of the interossi. You have pain, temperature, proprioception, and vibratory sensations, and even touch be diminished in the extremities in the trunk. And it can be combined, so you have what we called partial cord syndromes, and you have very different anterior, posterior, brown sequard, and all that. So you have to really test everything for these patients. And finally, you also have the abnormal reflex findings. That is hyperreflexia or clonus, the absence of superficial reflexes, and these pathological reflexes. So the extensor plantar response instead of flexion. You have the Hoffman reflex, and I usually use the Hoffman reflex just to rule out any kind of upper motor neuron involvement. So it's very easy. You can do that in all your patients, and with that, just a quick check if the patient has any kind of spasticity, and with that, making the diagnosis of cervical myelopathy. We use scales. The older one is this Nurix scale. It's very easy. It's from 0 to 5. And as you can see there, it analyzes both your motor weaknesses. It analyzes your gait and also the possibility to work. And with this, you can grade these patients from 0 to 5. The JOA scale is more fine. It's more granular. It goes for the lower limb motor dysfunction, the lower limb sensory deficits, the trunk sensory deficits, and finally the sphincter dysfunction. And with this, it's a little bit more granular than the Nurix, as you can see. So once you have clinically established what you think of your patient, whether it's just neck pain, whether it is a radiculopathy, or is myelopathy, or is some kind of combinations, you can go for imaging studies. Now, you don't need imaging studies for every patient you see with neck pain. They can be delayed for 4 to 6 weeks unless you have serious pathologic involvement of cervical spine, or it is suspected. I mean, if you suspect of myelopathy, you should go for exams now. If the patient only has neck pain, you probably can just treat the patient now, wait for it to see if he recovers, and then go for the exams. But if the patient does have some kind of motor or sensory deficit, you probably should go immediately for the imaging studies. So you can grade this depending on the clinical pictures you see. So physical examination and clinical evaluation are very important before looking at your imaging studies. And I say that because you also have to understand that imaging many times will show you problems. I mean, around 50% of patients over 60 will probably have some kind of degeneration on the spine. And so it's very hard to really correlate what the patient has to the findings you see on your imaging studies. So really, really important to really understand what the patient has before going to the imaging. Now, warning signs that should prompt you to go immediately for some kind of further investigation. Now, if you suspect a fracture, that means relevant trauma in an adolescent or adult, or even a minor trauma in an elderly patient, or if the patient has, for instance, ankylosing spondylitis or any other kind of ankylosing condition of the spine, you probably need some kind of imaging. If you suspect of a tumor, pain that's worse at night, unexplained weight loss, a history of neoplasm, or an age of over 50 or less than 20, also look for some kind of additional imaging or analytic study. Infection, also fever, chills, night sweat, unexplained weight loss, systemic infection, immunosuppression, or intravenous drug use. It's also should prompt you to immediately go for this investigation. And finally, if you have some kind of neurological injury, so especially if it is a progressive neurological deficit, you should go for advanced imaging in these patients. So what are the imaging studies that you can use? So first of all, of course, X-ray. Why the X-ray? The X-ray is very cheap. The dose of radiation is very low. You have it in your office, probably, so the patient will do it immediately, and it can help you sometimes. I mean, if the patient has neck pain, if you take an X-ray, you'll see the major findings of this neck. So if you look there, it's obvious the patient has some kind of spondylosis or arthrosis around the C5, C6, C7 discs. You can see the osteophytes. You can see the uncovertebral joints on the AP view, but it just tells you that this patient has some kind of degeneration. It doesn't tell you that the patient has pain. So it's very hard to correlate these findings with the actual pain of the patient. Now, it can be interesting if the patient does have some kind of major abnormality in the spine, I mean, the fused segments, instability of the spine, that can be helpful in that diagnosis. But on all other conditions, the X-rays will not be that useful, but it's very easy to get, and so we do it most of the times. It may also be interesting in patients where you suspect of some kind of narrowing of the canal. And you can use this indices like this one, the torque, Pavlov torque index, where you divide the AP dimension of the vertebral body with the AP dimension of the spinal canal. And if it is below 0.8, you will probably have some kind of narrowing of the canal, congenital narrowing of the canal. You can also look at the anterior part of your spinal process, of your lamina, sorry, and where it crosses the facet joint, the facet pillar, sorry. And if it's very close one to the other, it's also a sign that you have a congenital narrowing of the canal. So the X-ray can actually bring you some information for your patient, so I usually use it. We also use very often the dynamic flexion extension X-rays that can tell you whether or not you have dynamic instability. So translation, that's more than 3.5 or sagittal angulation of over 11 when compared to the adjacent levels. That can also tell you that this is some kind of instability. So that's also an important sign. The CT scan, well, CT scan, of course, it's interesting. The CT scan is cheaper than MRI in most places. It's easier to find also in most places. And the CT scan does have the disadvantage that the dose of radiation is much higher than it is within a simple X-ray. And so you have to really think carefully about it, especially if it's a very young patient. Now, the CT scan can easily find a disc herniation, although it's easier to find it in the lumbar spine. But the CT scan does not show you the details of your spinal cord. And that's why I usually prefer the MRI, because the CT scan will not highlight any kind of problems with your spinal cord. Now, the CT scan, I think nowadays is almost mandatory when you have very important degenerative conditions in your spine. So even if you have an MRI in this patient that will tell you that you have problems with your spinal cord, which will be obvious, the CT scan will help you establish where do you have calcification, and will tell you that you may have problems if you go surgically, if you go for surgical treatment on this patient, where you can have problems with adherences to the dura, and anticipate those problems in order to get safer surgery. Now, the gold standard for most of these cervical conditions will be the MRI. The MRI can clearly show you this disc herniation. And if you have this T2 weight images there, where it's brilliant, where it's high intensity of the disc, it clearly shows you that it's a very recent disc herniation. And with that, you can also manage and decide your treatment for this patient. It's also mandatory on your myelopathy patients, because on T2 and especially on the STEER, on the fat set ponderations, you can see the spinal cord modifications. You can see intense imaging, intense signals, inside the spinal cord. And that tells you that you have some kind of edema myomalacia, and that can also tell you that that can be a long-standing problem, and also it can have an impact on the recovery of these patients. So in terms of prognostic factors that we use for the spinal cord in myelopathy, you can see high signal intensity on T2 weighted images in combination with low changes in T1. That means blood. So that's a poor prognosis of recovery. So these patients will probably not profit too much from the surgery. When you have a high ratio of T2 signal intensity between compressed and non-compressed segments, that are also a very interesting prognostic factor. And when you have a big number of high intensity segments in T2, that's also a bad prognosis factor. So you can use this to inform your patients of what the objectives of your surgery are. So you can tell them whether it's probable to recover from the surgery, or whether your surgery will probably only be to stop the progression of the disease instead of just getting the recovery. So I get you now a clinical case before moving on to treatment. And this is a 45-year-old male. This is a businessman, so a young patient. He's been having neck pain for over 3 months, and especially left arm pain, not that very important, but he has numbness. He really can tell you exactly where it goes. It goes to his lateral arm, goes down to his hand, and can tell you exactly. He goes regularly to the gym, and he finds now that his left arm is weaker than it was. So we cannot lift as much weight as he had. Now, when he also tells you that, yeah, he does feel that sometimes he feels it's difficult to button his shirt. He can do it, but it's different. The sensation on his hand is different. And you see he's walking, and it's perfectly normal. Now, when you examine this patient, you see a kind of a global motor weakness on his left arm. You do have some atrophy on his left arm. It's diminished grip strength. There are no sensation deficits. He does have hyperreflexia, and there is definitely a bilateral Hoffman sign. So that clicks me to think that this patient will probably have something more relevant than just a radiculopathy. So this is a young patient, so that's not typical for myelopathy. This is a patient that has neck pain. This is a patient that has arm pain. But then you look at the patient, and the clinical picture is more of a myelopathy. So you have to integrate everything, and you have to say, well, we really have to check this patient out because it may not be typical, but it definitely has some signs of myelopathy. And we take the MRI, and you can see there, this is a fairly young patient who has a really degenerated spine. You can see there the C4, C5, C6, C7 discs. They have protrusions. And you see on the fat suppression image on the middle that he has signal changes that go all the way down from C4 to C7. So this is a patient, and you see the axial cuts on the lower part, C6, C7, you really see a hyperintensity zone inside the spinal cord. So this is a patient that really has this myelopathy symptoms, and they correlate easily with the pathology you see on the imaging. We'll see this patient later on when we see what we do in terms of treatment. So when you think about treating these patients, the first thing you have to see is what happens if you just don't treat them. So what happens with time? So axial neck pain, most of the patients will improve with time. So you can do whatever you want. So most of the patients will somehow get some relief from the pain, especially from their flares of acute neck pain. Cervical radiculopathy also, up to 90% of them will improve with time. So don't rush to operate these patients because they'll probably do well without any kind of surgery. So you just have to treat the symptoms of the very beginning. Eventually, they will fade out and the patient will improve. And finally, there's cervical myelopathy. Now, cervical myelopathy is very hard to really get what is the natural history. So the studies are very old, but most of them will tell you that at least 2/3 of them will decline in 5 years. So that means that probably cervical myelopathy will need surgery earlier on than all of the other pathologies we're talking about here. And we really have to follow these patients very closely if we decide not to treat them surgically, okay? So this is what we can do. So conservative treatment, you have multiple options: medication, immobilization with cervical collar or others, temperature, either cold or hot, passive mobilization, traction, manipulations, injections, and now we even hear about stem cells and other things for the disc. So we also have that on cervical spine. It's definitely more advanced in the lumbar spine, but most of these things, if you look closely at the literature, you don't really have the real evidence for each of them. Now, we do have the evidence that it works, time works in these patients. So if you have a disc herniation, you should wait at least 6 weeks before deciding any kind of surgical treatment. If you have axial pain, surgery will probably do nothing to these patients. So you put your bets on conservative treatment, especially strengthening of your muscles and mobilization of your spine. And finally, have surgical treatment. Surgical treatment will move around decompression, fusion, and nowadays arthroplasty. And the combination of these can be used, and also the choice of approach, whether anterior or posterior, can be done in multiple ways. And you can do that minimally invasive, open surgery. Well, it's beyond the scope of this talk, but of course, that's the way to go. So general management guides for degenerative cervical spine. So first of all, non-operative treatment, initial approach of choice for patients with axial neck pain or radiculopathy. So these patients will be treated non-operatively. They will be treated for at least 4 to 8 weeks. And if you have cervical radiculopathy, you wait till then before deciding for a surgery. Then you have to deal with the patient and really get something that alleviates his pain, and look closely to these patients and see whether the patients are actually improving, or is there any kind of motor deficit that's worsening. Because if you have that, you should move to surgery. So these patients are patients that have to be followed closely during the time of these treatments. For neck pain, I don't see many surgeries that are really good. So usually neck pain will be only treated with non-operative treatment. When do we recommend surgery? Myelopathy. And this is kind of controversial, when should we operate on a myelopathy? So we know that the patients that recover, patients can recover even in later stages of their disease, but we know that the patients that really do better in the end are those that are treated earlier on. So in patients that have really mild symptoms of myelopathy, you can offer these patients surgery. If they decide, or you decide not to go for surgery, you have to follow them very closely, because these patients can degrade very quickly. And so around 10% of these patients will have a very steep worsening of their function, and they have to be operated immediately. So look closely at these patients. Don't let them just be out of your office and just be followed by their general practitioner. No, you have to follow these patients and understand that. Second recommendation for surgery is when you have significant or progressive neurological dysfunction. And that's also important for radiculopathy. So you have a motor deficit that's like a 4, and the patient progresses to a 3 in the space of a week. You probably should go for an operation for this patient, because it's not improving. Instead, it's getting worse, so it should be operated. And finally, if you have an appropriate course of non-operative treatment and the patient still suffers, of course, you should go for surgery and propose the surgery for the patient. So let's go back to our case. So remember, this was a 45-year-old male. So pain was for 3 months, neck and left arm pain with numbness. He had these symptoms and signs of myelopathy, and he definitely had these images of compression of at least 3 levels. So what we do here, So we decided to operate on this patient, of course. So this is myelopathy. This is a young patient, a very active patient. There are signs of spinal cord suffering. So we told him, you have to be operated. We have to be operated not in an emergence base, but really pretty soon. And for this patient, we decided to do a hybrid construct. So this is a 3-level. For a 45 very active patient, we thought that fusion would not be okay. So we did a standalone fusion on C6, C7, and a 2-level disc arthroplasty, which will enable him to still maintain his mobility in this middle cervical spine. The patient is now 2 months post-op and is doing really, really fine and is already recovered fully his strength on his left arm. So this is a very gratifying surgery that you can do for these patients. So as take-home messages of this talk, I'll tell you that degenerative cervical disease has mainly 3 very distinct clinical pictures: axial neck pain, cervical radiculopathy, and cervical myelopathy. Although they can be combined, they can see patients with different signs and symptoms of both of these 3 clinical pictures. You need a careful clinical evaluation to establish the correct diagnosis, to direct your management, and also to avoid unnecessary examinations that can lead to confounding on your diagnosis. A program of non-operative treatment is always reasonable in both axial neck pain and early symptomatic radiculopathy. Surgery is only reserved for patients with myelopathy, progressive or severe neurological dysfunction, or failure to improve. And with that, I conclude. So thank you so much. You are all invited to come to Porto whenever you'd like, and you have my email. So if you'd like to contact me, feel free to do so. Thank you so much.
Thank you, Nuno. Nuno, yeah. Thank you, Dr. Nuno Neves, for this wonderful presentation. And let's have a short Q&A. Can you hear me?
Yeah, perfect. Let's go.
Okay. Dr. Neves, what do you think is the role for an endoscopic discectomy in a cervical spine disease? For example, a young active person, someone who's in the 20 to 30 year age group. Do you think there's a strong role for an endoscopic discectomy?
Yeah, that's a great question because it's a hot topic nowadays, endoscopic surgery in the spine. So personally, I have no experience, so I don't do it. But yeah, it's very interesting because usually cervical spine, you would do anterior surgery, you do discectomy and fusion. And preservation surgery like open discectomy would somehow tear your muscles. So it was not very popular. But nowadays, with the possibility of doing that endoscopically with no disruption of the muscles, it can be a really good option, especially for patients who have either a foraminal stenosis that can be amenable by a drill, or they have a very soft herniation in a very posterolateral location where you can just pick it out and just preserve the rest of the disc. Yeah, so that's definitely a role for that.
Thank you, Dr. Neves. See, one of the last X-rays that you showed was a cervical disc arthroplasty and a fusion. So how do you decide which is the one that you're going to fuse and which is the one that you're going to replace? Yeah,
great question there. So yeah, so I think the role of arthroplasty now is still being refined. So it goes back many years ago. For my personal experience, we did that a lot in the early 2000s. Then we stopped doing that because we had some problems in the index level, so not at the adjacent but the index level, and now it's coming back. I'm using a lot of viscoelastic prosthesis, which I find very more interesting than mechanical prosthesis. And usually I would do only 1-level surgery. Now I have expanded to 2-level surgery also because the results on the literature are also very encouraging. And when I decide for hybrid fusions, usually I go for when I have a very degenerate level with lots of osteophytes and facet arthrosis. I would definitely go for a fusion there. And in this patient, we did have that on C6, C7. But the other discs, you only had protrusions. You didn't have really facet joint arthrosis. So I did go for arthroplasty in those levels. So I decide a little bit on these different factors and also the age group. So an older patient, not very active, I will probably just do a fusion.
Thank you, Dr. Neves. And what about cervical laminoplasty? For example, we talk about open door, closed door, then the Hirabayashi's technique. And of course, it widens the cervical canal, right? So do you do that for the cervical myelopathy?
Yeah, that's also a good question. So laminoplasty is very popular in Asia, especially in Japan. So every town in Japan has its own technique of laminoplasty. It does have a factor. You need a lordotic spine in order for it to work. So that's the first thing. The second thing is that we find that laminoplasty, although it's movement sparing surgery, it allows movement, it always restricts a little bit of your movement, so around 50%. So it's not that very interesting at all. And many times I see that I do have compression on the front, so I prefer to go directly on the front. And finally, we do have some wound problems with posterior surgery. So I do it sometimes, especially older patients, where I think that posterior surgery can be less challenging for multiple levels, for the esophagus, for his larynx. So I go for the posterior. I do sometimes laminoplasty, and I still do lots of laminectomies, especially combined with fusion. And sometimes in very older patients that are have lots of comorbidities, I can do also isolated laminectomy, but that's just a very small set of patients where I think it can make a difference.
Thank you, Dr. Neves. Just one last question before we wind up, Dr. Neves. Now, if you look at the treatment options, you have a disc arthroplasty and you have disc fusion. So look at the long-term outcomes between these two procedures. Do you think there's a significant difference? Do we have enough long-term data for disc arthroplasty? And do you think complications are slightly higher with an arthroplasty?
Yeah, yeah, I don't have the answer for that, but it's a very good question. And philosophically, we can think about that. So the idea for doing a disc arthroplasty is to preserve movement. So that's one thing. It's not very important because if you think each disc will move around 7 degrees, so it's not that important. But if you preserve that, you think maybe with that I will prevent adjacent segment degeneration. So you have some papers that will tell you that. You have many papers that will say it doesn't work at all like that. And you have a very recent paper from the Netherlands that actually shown that it doesn't make any difference at all. So possibly arthroplasty is not that important. Now, I think that if I have two options that are equivalent, the one that gives me more movement, if it doesn't have more complication, I think it's better. So I don't like to restrict movement. I don't like to do that in any joint. So in the cervical spine, I don't like to do it either. So I prefer to do cervical disc prosthesis. Now, long-term outcomes, that's a great question, because if you look at hips or knees, when you talk about long-term outcomes, it's not 5 years. It's 12, 15, or 20 years. And we still don't have that much data on 20 years, for instance, in cervical spine. But we do have lots that now have 10 years. And the results are very encouraging because the patients do well. And most of your prostheses still work. And that's one thing that people used to say at the very beginning. It's a very expensive fusion because it stops working at 2 years. And it's simply not true. And we have that experience with our patients, and at least 80% of them, with more than 10 years of follow-up, they were still working. So I think it's an option. I don't think it's definitely that different from fusion. But if you go for multi-level fusions, maybe if you put at least one of them moving, maybe it's better than just fuse everything.
Thank you, Dr. Neves. Dr. Neves, I think that's all the questions that we have for this session. Thank you for this wonderful presentation, and I'm sure this is going to benefit a lot of people.
Thank you so much, and I hope you have enjoyed it.